Okay, so today we're going to talk a little bit. This is a paragraph or a chapter that I'm going to put in a textbook that's going to come out called Introduction to Chronic Disease Prevention and Management. And I volunteered to add this if they like it. So far so good. I sent them a preliminary copy of this. This is not fully corrected, but it has been updated so that it has all of the references that we need in it. So introduction to hormone optimization, your guide to anti-aging strategies. And as you know, this is kind of our Bible. This is what we do. This is how we approach anything. So introduction to hormone optimization. Hormones are specialized chemicals synthesized within the body, and they carry messages from originating to target cells. Uniquely adapted to receive these signals, end organ cells play a crucial role in maintaining the body's homeostasis and regulating various metabolic functions. So as you can see, this is sort of written towards physicians. It's a little bit more sophisticated. If you think it's too if it's too wordy or too complicated, let me know. Okay. And let me know if you think we need some corrections. As women mature into and through beyond menopause, and as men experience andropause, they often face significant disruptions in both body and mind. These changes affect how information is processed, energy is metabolized, and function is achieved. Over time, the expected course of action is a rapid deterioration of capabilities compared to when we're in our 30s, 40s, and 50s. Aging is often a sign of degradation of a quality of life, fatigue, energy, loss of motivation, weight gain, decreased sex drive, depressed mood, anxiety, irritability, loss of memory, concentration, or symptoms of a body in decline, as we all know. We do have knowledge and tools to deal safely with to extend our youthful appearance and vigor from aging's fallout. I say I have to fix that. The key to retaining a vibrant, mental, sharp existence well into our 80s, 90s, and even hundreds is to restore and optimize declining hormone levels. The key is to mimic Mother Nature, i.e. bioidentical hormones, chemically equivalent to those we produce naturally. So the tarantula was a fake car on a TV show called The Dick Van Dyke Show from the early 60s. It was polished and shiny on the outside, and inside it had a new car smell. Under the hood, the tarantula was perfect. The oil was clean. The brakes and transmission fluids were topped off. The front end was aligned, and the engine was waiting for your touch. For women, bioidentical hormone optimization reduces night sweats, hot flashes, vaginal dryness, itching, painful. I must have left something out. I don't know why that's in there. So we're going to have to fix that too. Painful intercourse, fat loss accelerates, muscle tone responds to exercise once more. Sex drive, mood, memory, concentration all revert to a more youthful era. Wrinkles smooth, bones get rehardened to protect from osteoporosis, and the risk of heart disease is reduced by up to 50%. For men, bioidentical hormones offer numerous benefits, including energy enhancement, muscle tone, better exercise endurance, more effective fat loss. It signals significantly boosts sex drive and performance, sharpens memory and concentration, and promotes better sleep. Additionally, it can stimulate scalp hair regrowth, reduce joint pain, aches and pains, strengthen bones, improve cholesterol levels, and contributes to heart disease protection. So bioidentical hormones are exact replicas of the hormones naturally produced in the body, and they are derived from plants usually and manufactured by traditional pharmaceutical companies or compounding pharmacies. So when we first started doing this, we could only get them from compounding pharmacies, but there are a lot of FDA-approved drugs now that are bioidentical. Synthetic hormones contain unnatural chemical ingredients, and over the past 2 decades, medical studies conducted in Europe reveal that bioidentical hormones are safer and more effective than synthetic ones. Natural estrogen increases endothelial nitric oxide, protects vascular function. It is cardioprotective. Estradiol decreases the risk of acute myocardial infarction and diabetes mellitus. Internal carotid artery lumen measurements are 224% wider when a patient has adequate estradiol levels for 6 months or longer. Natural progesterone improves sleep, mood, acts as a diuretic, has no effect on glucose metabolism, maintains estrogen-induced arterial dilatation, improves lipid profiles, has a beneficial effect on cardiovascular function, reduces estrogenic stimulation of breast tissue, and protects against breast cancer. Natural progesterone effects are often confused with synthetic progesterone, termed progestins. Natural progesterone stimulates the production of new bone, enhances the function of thyroid hormones, improves libido, restores cell oxygen levels, induces the conversion of the estrone to an inactive estrone, promotes Th2 immunity, and is neuroprotective and promotes myelination. Natural progesterone decreases the risk of breast cancer. A study of 80,000 postmenopausal women over 8 years using different kinds of hormone replacement found that women who used estrogen in combination with a synthetic progestin had a 69% increased risk of breast cancer when compared to those who never took hormones. Women who used natural progesterone in a combination with estrogen, with natural estrogen, I have to fix that, had no increased risk of developing breast cancer compared to women who did not use hormones. They also had a decreased risk of developing breast cancer compared to those who used progestins. And here's a little clinical tip: never, ever, ever use synthetic hormones for any reason, and you have to pinky swear to that.
Yeah.
Okay. All right, so that's kind of the introduction. I don't know. Is that okay? Is that too wordy?
No, it's great, sir. Yeah.
Okay, so here are the hormones we're going to look at. I call them the Magnificent Seven primary ones: testosterone, estrogen, progesterone, growth hormone, thyroid hormone, cortisol, and insulin. The 3 secondary ones: DHEA, pregnenolone, and prolactin. And then I have 7, the 7 big supplements that we use: omega-3 fatty acids, MCT oil, vitamin D, probiotics, prebiotics, glutathione, L-threonine, and branched chain amino acids. So that's what we could cover. So each page here is just one page, a few tips on each hormone, and then a table. Here's the testosterone table. Deficiencies, what you see with symptoms of deficiency and excess. Okay, so that's the way I have it structured. Testosterone is much more than sex. It acts as an antidepressant, an anti-anxiety agent. It improves mental clarity, strength, energy, mood, motivation, a sense of well-being, muscle tone, sexual energy, and sexual desire. Androgen receptors throughout the brain positively impact cognitive function and exhibit ongoing effects in the mature brain. Testosterone attenuates inflammatory cytokines while increasing interleukin-10, an inhibitor of pro-inflammatory cytokines, interferon gamma, interleukin-3, TNF-alpha, and GM-CSF. Testosterone protects against mitochondrial dysfunction, controls neuronal excitability, and increases seizure control. Testosterone alleviates pain, particularly in the low back and knees, and moderates anorexia nervosa. Testosterone deficiency results in depression, fatigue, suicide ideation. Testosterone levels are inversely proportional to depressive symptoms. Free testosterone levels in the lowest quartile presage the highest incidence of depression. And then we got a table here of symptoms. So deficiency testosterone, weak flabby muscles, low self-esteem, anxiety, depression, poor sense of self-worth, urinary incontinence, for women, vaginal dryness, for men, urinary dribbling, poor sexual function, poor libido, thinning hair, fatigue, dry skin, poor skin elasticity. Too much testosterone, aggressiveness. I don't really see that all that much. Every once in a while, someone's sensitive to it when we treat them with it. But the road rage kind of thing is kind of a known thing out there. But I don't know. I don't see it all that often. I don't know what your experience is.
It's so funny. A guy asked me that on a consultation yesterday. He said, "I'm worried about road rage," and I told him that at physiologic medically replaced doses, we just really don't see that. It's just it's very very rare that happens. I've never seen it happen either.
Yeah, I agree. Agitation, irritability, oily skin, oily hair, acne, skin breakouts on the neck and shoulders, I don't have one here. Redness in the face. This is in the extreme. Redness in the face, peripheral edema, and elevated blood pressure. So I work with an outfit called Andrologics. You ever hear of them?
No, sir. Never heard of that.
It's a it's like an online hormone company. They've been around for a long time. And
Huh.
I've been with them for 10 years. When I first started with them, when I moved out here, when I first started with them, they sent me this guy. He was like 70 years old. They use really high doses of stuff, and they'll use like 200 milligrams of testosterone IM plus oxandrolone plus nandrolone. I mean, they use a lot of stuff. Yeah, this guy
Well,
he was 70 some years old. He was kind of skinny. I said, this seems overdosed too much to me. And I said, well, they've been doing this a long time. I guess they know what they're doing. So I signed off on it. He came back 2 weeks later. He was, I mean, he was full red in the face. His pressure was 200 over 120. We got a testosterone level on him. It was 2,500. It was like, so, um, so, so now from then on, I didn't say, well, they know what they're doing, so I'm not going to say anything about it. So, okay. So I mean, that's the way I have this set up. Okay. This is just sort of short, sweet, and to the point. And you can, at your fingertips, look at any one of the hormones. I don't know if this is helpful. Obviously, you can write a whole book about each one of these hormones. Estrogen maintains cerebral blood flow. Oxygen, lactic acid production, modulates pain, prevents apoptosis, and inhibits progression of neurological deterioration and neuronal loss in the central nervous system. Estrogen lowers the risk of PTSD after trauma and aids in the recovery from strokes and traumatic brain injury. Elevated estrogen levels in men from increased aromatase activity, from testosterone metabolism. Estrogen excess is a byproduct of obesity, alcohol excess, environmental estrogens, estrogen-containing foods, zinc deficiency, liver dysfunction, superphysiologic testosterone therapy, calcium deficiencies, and diabetes. Excess estrogen leads to headaches, insomnia, bloating, mood swings, anxiety, depression, panic attacks, fibrocystic breast disease, breast tenderness, women vaginal spotting, fibroids, endometriosis, ovarian cysts, and gallstones. Symptoms of estrogen deficiency include hot flashes, night sweats, brain fog, belly fat, generalized pain, depression, memory loss, PTSD. Okay. So here's our table. And we just talked about this. So estrogen deficiency, poor libido, vaginal dryness, urinary incontinence, hot flashes, night sweats, brain fog, memory loss, amenorrhea, thinning skin, osteoporosis, diabetes, elevated lipids, and heart disease. Estrogen excess, fluid retention, hypothyroidism, fatigue, insomnia, bloating, anxiety, fear, breast swelling, tenderness, severe headaches, excess menstrual bleeding, weight gain, increased breast cancer incidence. In men, you get breast enlargement, prostate enlargement, urinary retention, emotional lability, tearfulness. Okay. So that's, would this have been helpful for your study for your test?
Yeah, I think it would have been, very helpful. The thing is on this exam, they asked a lot of wild stuff, a lot of immunology, biochemistry stuff, and it was a regular, you know,
Did they still give you, did they have a class ahead of time, a week before, where they
oh,
pretty much give you the answers?
oh, not at all. What's her name? Pamela Smith does on the in your academic portal online in your account, it has an exam review, which is totally unhelpful. She does like a 20-minute PowerPoint presentation. These are the general categories you need to know about: hormones, immunology, biochemistry. You
Yeah,
know?
well, so we figured that out. We didn't need that, right?
Yeah, so that was not helpful at all. So, I read and reread that book. I read that entire textbook, twice from cover to cover, and made notes, and um, so that's
So you got your fountain pen, huh?
yeah.
Do they have a graduation ceremony too?
Oh, I don't know. There's Joan called me and congratulated me. That was very nice. And then I don't know what happens, for the fellow. For the fellowship.
Yeah, I
And
think I think I remember there was a graduation ceremony, like in one of the big weekends that they do, and on their when they do the cocktail party, like on Thursday night or something. I seem to remember something like that.
okay,
I know it was a long time ago, so that the way they do it now, everything's online. So
yeah, I know. I wish they would make it a little more, a little more, special. A4M is still far and above the gold standard. I mean, there are these certification, functional medicine certification programs, that are out there that are all over the place. That they're not, they're just they don't even compare to A4M. But what I do hear, Dr. Clearfield, I was talking to a couple of fellows, advanced fellows in Dallas who are, with A4M, their docs, and they went through the program, a while ago. They said that they agreed. They said A4M is still, the best, and they went through many other they went through several programs afterwards, and they were saying that it's the gold standard. When you go into age management medicine, anti-aging medicine, A4M is like going to university. But a couple of them were saying that they get there's so much information. Many of them, when they finish both fellowship, the standard and the advanced fellow programs, they were just confused. They had no idea how to really put it all together, and really synthesize the information, and what to do Monday morning type of thing when seeing a brand new patient.
well,
Like
that's why I do what I do. So
exactly, exactly. And so that's how I think a lot of these other programs are attracting even graduates from A4M, because they are that guys are like, they're kind of confused. Like one guy
mhm.
told me the other day, he said, I'm pretty good at hormone stuff, but I really don't know what to do with all the autoimmune stuff and treating vascular disease and post stroke syndromes and bad endocrinopathies. I mean, and I learned all that. They give us all this data, over all that time, but I really need to know how to do all this testing. He was going through the organic acid testing and the heavy metal screening and the neurotransmitter testing, and how do you apply all that? And I was like,
Mhm.
gee, I mean, did you learn about all that stuff? And so he was just making the point that he just really didn't know how to make it functional.
Right.
One of the things they do know is hormone therapy, but all the rest of the stuff is still a little mystical to them. So I think that's
Mhm.
where a lot of these other programs are, kind of grabbing them, and they're kind of advertising. That's great that you went through I4M or IFM. People from IFM say they have the same complaint, but
Mhm.
it's they just don't know how to. And I think the hormone stuff, a larger majority have. It's all the rest of the stuff that they have trouble kind of synthesizing and putting putting into practice. So
All
you
right.
know.
So you let me know what you want to do the microbiome, right? So
Yeah, sure. Eventually, yeah, we can go through.
yeah,
We'll go.
let me put something together for that. So should we continue on here or do you want to do some go
Oh,
something else?
no, that's great, Chip. Yeah, no, that's wonderful.
Okay. So progesterone dominates the second half of the female menstrual cycle. It's the equivalent of the behind the scenes political operative. It cleans up estrogen's messes. Progesterone relieves estrogen dominant headaches, breast, uterine, and ovarian cysts, moodiness, abdominal cramps, and PMS. Progesterone is calming. It regulates fluid balance and blood sugar and improves thyroid function and mineral balance. It relieves menopausal symptoms while decreasing the risk of endometrial cancer, fibrocystic breast disease, osteoporosis, and heart disease. Progesterone improves mood, sleep, acts as a natural diuretic, maintains estrogen-induced arterial dilatation, and reduces estrogenic stimulation of breasts. Progesterone, alloprogesterone, and DHEA protect neurons from oxidative stress and in neuroregeneration and myelination regeneration. It aids in the reduction of inflammatory cytokines, particularly interleukins 1B and TNF alpha, and the result is an anti-anxiety, antidepressant, anti-aggressive, anti-inflammatory, anti-stress, and anti-convulsant behavior. So in other words, it calms things down. Remember, progesterone is the first hormone that starts to deteriorate when the females go through perimenopause, and then you get these symptoms: agitated, irritable, can't sleep, poor libido, headaches, short-tempered. You know, the common prescription is SSRIs, SNRIs, benzos, mood elevators, mood depressors. You know, I always like to say, whoever made us didn't make a Prozac deficiency.
That's right.
All right. 4 weeks of progesterone, even a 5% cream, will make a world of difference. So symptoms of progesterone deficiency is PMS, again, mood swings, depression, anxiety, breast tenderness, breast swelling, excessive menstrual bleeding, spotting between periods, lowered HDL, insomnia, poor libido, headaches. So part of that is low progesterone is excess estrogen. So, you know, remember, we measure that balance. Too much progesterone, usually that happens when either there's no estrogen or we gave too much progesterone. Worsening hot flashes, increased cortisol, increased fat storage, increased appetite and carb cravings, depression, feeling drunk or hungover. That's our usual symptom that we see. And then bloating or water retention. When I first started, there was a outfit called the Wiley Protocol, and they would use
I heard about that.
800, 1,000 milligrams of progesterone a day, and so you can imagine what happened pretty quickly. So I don't remember all the details, but I remember, you know, whoever Wiley was, it was a female, was like a clerk or something like that. It didn't have any medical training from what I remember. So, but that was pretty popular for a while.
Wow.
So, growth hormone preserves memory, improves concentration and mental clarity. Untreated growth hormone deficiency results in weight gain, anxiety, depression, poor cognition, loss of memory, obsessive compulsive activity, brain fog, dark moods, paranoia, outlandish, destructive, and criminal type behavior. Growth hormone deficiency results in what we've known as loss of executive function, with cognitive processing. So that's memory, concentration, being able to start projects, being able to finish projects, being able to multitask adequately or not, or easily or not. Obsessive compulsive tendencies, dark moods, paranoias. Those are the questions that I ask. Growth hormone deficiency and traumatic brain injury is the most common hormone deficiency. Within 3 months, 20% of traumatic brain injury patients, and these are mild traumatic brain injury patients, exhibit growth hormone deficiency. And if left untreated, it actually rises to 35 to 40% of them after a year. So again, growth hormone deficiency, anxiety, depression, hair loss, decreased sexual function and libido, decreased muscle mass and strength. So that a lot of that's like testosterone, dry skin, elevated triglycerides, fatigue, high levels of LDL cholesterol, insulin resistance, and then again, memory, concentration, being able to start projects, finish projects, multitasking, obsessive compulsive tendencies. Um, signs and symptoms of growth hormone excess, decreased quality of life, sarcopenia, loss of exercise capacity, osteopenia, loss of strength. It's almost like over-exercising. Glucose intolerance, dyslipidemia, increased fragility of skin and blood vessels, decreased skin thickness. So again, the whole idea behind this manual is so that it's, just sort of like a quick reference. Thyroid hormones, that's your gas pedal. It provides fuel for every organ of the body. And again, like all the hormones, it's Goldilocks. You need not too much, not too little. Thyroid influences dopamine, serotonin, glutamine, and GABA. The thyroid acts as a fine-tuning mechanism and functioning of neural networks and tempers psychotic ideation. The thyroid manages a patient's energy and mental clarity. So if you go to a search engine and type in thyroid and depression, you're going to get like 80,000 hits, over last 5-year period. The first symptom, by the way, of thyroid issue usually shows up about, on average, 5 years before the thyroid hormones themselves start showing signs of hypothyroidism, is anxiety. So usually it's retrospective. Somebody said, well, I've been anxious for the last 10 years. And, I didn't know what was wrong with me. And then 3 years ago, my doctor sent me for a blood test, and my thyroid is running low. That's pretty typical. Okay, so there's your clinical pearl there. The first symptom is anxiety, and it usually comes out of the blue. The patients say, well, I wasn't that way before, and it happened like in a month or two. I became anxious, and it never went away. 98% of the patients have hypothyroidism. And again, thyroid deficits lead to fatigue, depression, poor cognition, psychosis. Thyroid symptoms, hypothyroidism, are dry skin, dry nails, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long, thinning of the outer third of the eyebrow. So we talked about the eyebrow before.
Yes, sir.
You know how to look at somebody's eyebrows and become a mini endocrinologist, right? Right. Remember, the outer third of the eyebrow, that's your thyroid. The middle third is a growth hormone, and the inner third is your sex hormone. So for males, it's testosterone, and for females, it's estrogen. So you look at a teenager and they have the unibrow, and they're always plucking it away, right? Especially
Right.
the girls, right? And that's what it is. It's the hormone effects on the eyebrows. And then when you go to your nursing home later today, go take a look at the ladies sitting there in the lunchroom, and look at their eyebrows, and you'll see that they're barely there.
How about in the ICU before that?
Yeah, I don't know about the ICU. It depends on how many trips the customers have made there, I guess.
That's right. Yes, sir.
So, I mean, I don't really deal with renal failure people a lot, but I know they're there a lot. So you may want, why don't you do some observations and report back on that.
Yeah.
Okay, so here's our charts. Hypothyroidism, everything slowed down. Hyperthyroidism, everything speeded up. Right, that's pretty much it. Right, you got that?
Yes, sir.
Okay. Two caveats on our checkoff list when we give patients that for hypothyroidism that you might not think about. One is decreased concentration, and two, word salad, and they'll check those off.
Huh.
Okay, so like, did you ever hear your vice president talk? That's word salad. So, and the patients they'll check those off, and you'll find. I don't know about you, it's because what we do, but about a third of the patients who show up, brand new, and they have sort of vague complaints, have some sort of thyroid issue, and don't know it.
Yeah.
So I never saw that back home, but I think I know more now than I did then. So I keep thinking, how much did I miss?
Yeah.
But we didn't really know. So cortisol regulates electrolyte balance, blood sugar cravings, immune response, and the effects of stress. There you go. So, I liken cortisol to the little programs down at the bottom of your computer screen. There's a microphone there, and there's like the internet connection, and maybe the battery if you're run on a laptop. If you need it, and there's like a little arrow up, and when you hit that, things will come up. Like mine has Google comes up, Drive, and Bluetooth, and Zoom comes up, and the printer comes up. And so you hit that, you do what you need to do with it, and then you hit it and it goes away. That's cortisol. So in an ideal world, you have a stress, the cortisol levels go up, the stress goes away, and then the cortisol levels go back down to the baseline, waiting to be necessary. That's your fight or flight. But of course, in the world that we live in, we got this stress that goes to that stress that goes to the next stress, and the adrenals are flood the body with cortisol, and it never goes back down to the sort of low level that it was meant to be. And eventually, you end up with not having enough cortisol, and we get that kind of burned out fatigue. Cortisol fatigue is intermittent. Testosterone or thyroid fatigue is constant all day long. So symptoms here are usually the patients wake up in the morning tired. They need something to keep them going in the middle of the morning. They have in the afternoon, they feel like they need a nap. By dinner time, they're exhausted. Later at night, 8, 9, 10 o'clock, they get a second wind, and then they're wide awake, and then they have trouble sleeping. And there's usually sugar or salt cravings with it. Too much cortisol, you have, again, salt cravings and food, high in sodium cravings there. You can become hypoglycemic under stress and experience, again, for females, PMS, perimenopause, menopausal symptoms. Depression, fatigue are common, and the ability to handle stresses are diminished. Patients complain of muscle weakness, histamine-like allergic reactions. You get a lot of skin reactions. They'll say, oh, my skin's broken out. It's nerves. Lightheadedness when rising from lying down or sitting, and diminished libido. So the controversy over adrenal fatigue, does it really exist or not? The endocrinologists say it's all a bunch of hokum. Well, there's either Addison's disease, which is not enough cortisol, or Cushing's disease, which is too much cortisol. Did I get that right? I think I got that right.
Yes, sir.
Right. But
yes.
There are all of these symptoms that you get that are similar, but in between. But it's not, frankly, Addison's. It's not, frankly, Cushing's disease. But they have all, and this other, they tell it, well, your numbers are okay, go home. And that's kind of where we come in. So I call it like Mr. In Between. And that's at least that's my idea of what adrenal fatigue is. Does that seem reasonable to you?
Yes, absolutely.
Yeah. So again, these are the symptoms. And you can measure cortisol levels. You have to do an AM one and a PM one. I like reverse T3. I think it's pretty accurate, and we get it. With the routine. You don't have to worry about the time of the day. You got the blood work. You don't have to worry that they shook the cells up, and and all sorts of nonsense that you'd have to worry about trying to get adequate cortisol levels.
So how are you using how are you really working the reverse T3 doctor, when you're managing adrenal issues, cortisol issues?
Again, we follow it all along. Usually the symptoms that I just mentioned, you'll find them when the reverse T3 is over 15, and we like it under 15. So, and you will find that, and again, so then we do, they talk about stress reduction techniques, yoga, Tai Chi, that kind of thing. That's the wink, wink. That's like, the cholesterol drugs, diet and exercise first, and then use our drugs, right? So, so first line, we use, adaptogenic herbs. The main ones are rhodiola, cordyceps, and ashwagandha. And then every company has slightly different offshoots of it. We use a bunch of them. We use Zymogen's one. We use Orthomolecular. Dr. Wilson, who got the one who first wrote about it, has his own brand. They're pretty good, except they're kind of expensive. So that's the first line. The second line, would be, well, it's the second line, actually. The first line is stress reduction techniques. The third line is adding in adrenal extracts. And then lastly, we use low dose cortisone, hydrocortisone. So as long as you keep the hydrocortisone under 30 milligrams, you really should have very little side effects, especially the big ones, hyperglycemia, joint destruction, weight gain. You really shouldn't see too much of that. We usually start, so hydrocortisone comes 5 and 10 milligrams. We usually do 7.5 milligrams, so 1.5 in the AM, 5 milligrams, one pill at noon, and 2.5 milligrams or half a pill. You want it before 6 p.m. because it will keep them up. So that's kind of how we start. If they don't want to break up the pills, so it's 15 milligrams a day at that rate. You can do 3 5s if you want, or 10 in the morning and 5 in the afternoon. Okay, that's pretty much it. The osteopathic way, right? Find it, fix it, leave it alone.
That's right. The osteopathic.
There you go. I just gave you the whole adrenal fatigue world in 5 minutes.
Wow, that is awesome.
Insulin, regulates glucose production. It is a peptide. It counteracts the actions of cortisol and adrenaline. It helps the body repair itself, converts glucose into triglycerides, maintains glucose levels at a steady rate, and plays a major role in serotonin production and enhances muscle development. Estrogen and testosterone will lower blood sugars in females and males. Progesterone raises blood sugars. So you need to keep that in mind when you're using insulin, okay? So again, insulin deficiency, bone loss, depression, fatigue, insomnia, excess thirst, frequent urination, fatigue, anxiety, depression, irritability, confusion, lightheadedness, a rapid heart rate. Too much insulin, acne, asthma, you can get cancers if it stays up too high, low estrogen levels, migraines, hypertriglyceridemia, infertility, insomnia, osteopenia, osteoporosis, and weight gain. Okay? So usually as time goes on, you become insulin resistant and insulin levels rise. Insulin becomes less and less responsive. Normal blood levels are usually around 2.6 to 25. I don't remember what the units are. We like it under 5. That's kind of what we shoot for. So I think we've talked about, remedies and medications in the past. The secondary hormones, DHEA. DHEA is actually an FDA-approved antidepressant for chronic or major depression. It was approved in 1952, believe it or not. It's a mood regulator. It builds energy and confidence. It improves one's sense of well-being. It decreases visceral and subcutaneous fat, reduces serum like LDL and triglycerides. It improves bone density, insulin resistance, insulin sensitivity, myelin sheath production. The immune system and allergy symptoms are diminished. It raises growth hormone levels. It promotes wound healing and lessens fatigue. It's basically a mini testosterone. It's one of the precursors. Low DHEA manifests as dry skin, dry hair, flabby muscles, especially in the abdomen, scant hair under the arms, pubic atrophy, noise intolerance, and deficient libido. So somebody who's got noise, loud noises bother them, take a look at their DHEA levels. I think the next one's going to be pregnenolone. Pregnenolone is light sensitivity. So noise sensitivity is DHEA, light sensitivity is pregnenolone. A little tip for you there. Okay, so symptoms of DHEA excess mimic those of excess testosterone, fatigue, anger, deepening voice, insomnia, mood changes, excess facial hair, acne, sugar cravings, restlessness, sleep. I don't see this a whole lot. I don't know about you. You will see this. You'll see high DHEA levels in polycystic ovary syndrome. And even if the testosterone levels are sort of normal high or even high, but you will see high DHEA levels. High DHEA sulfated are neuroprotective. Low levels lead to cognitive decline. So again, sort of a mini testosterone. Um, and another clinical pearl, when you're treating somebody with testosterone and the DHEA levels, there's like a negative feedback. And so usually after about 6 months to a year, I stop using it because it just doesn't get us anywhere. The blood levels either don't go anywhere or decline after when you're using exogenous testosterone. So you got somebody who's new and all their levels are low. If you use DHEA and pregnenolone, you're going to stimulate the whole pathway to get going again. But after about 6 months to a year, the DHEA it kind of becomes insensitive to it. So I kind of back off at that point.
You have one of the and you haven't seen. I know one of the things that you know. I don't know why they put it in black and white, but like a friend they were talking about. Of course, DHEA does nothing for testosterone in men. That has many other applications for males, but testosterone
Right.
doesn't
Yeah.
really.
Yeah. I think I remember that from somewhere. So
Yeah.
the DHEA doesn't do it. It doesn't raise testosterone levels in men, but it does in women, I think.
Yeah. Um, One of the things that I see all the time here, and we just kind of work through it. That is, what I do with the patients here is invariably, Dr. Clearfield, and they have normal labs, like they'll have normal prolactin levels, and
Mm-hmm.
their E2 levels will be trending normally, but new starts on testosterone. I would say 6 or 7 out of 10 males on a follow-up visit will say, "Man, I felt great for the 6 weeks, and now my tiredness is coming back, and my lack of drive is returning, and it's like it isn't working anymore." But their levels will be fine, and they have no aberrant changes on biochemistry. I see this a lot, and do
Mm-hmm.
you kind of have any thoughts, Dr. Clearfield, of what's causing that? Why guys report that so much?
I don't know. There's some theories that you become like testosterone resistant.
Yeah.
So it might behoove you to try and cycle it a little bit. Um, take them off of it for 2 to 4 weeks and then start it up again.
Okay.
Do that once every 6 months. So we will do that.
Does that and that helps? That
Yeah,
helps.
that does help. Yeah.
Okay.
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 And then you have to sometimes look at lifestyle issues too. I mean, if they're drinking and smoking and hanging out in casinos too much, that's you're swimming upstream.
Visiting those places, those uh, those ranches, and
Well, you got ranches where you are. We have casinos here. So, um, pregnenolone is the hormone of memory. Full stop. And not enough pregnenolone, bad memory. So we measure that, on everybody. Most of the time, the lab values will correlate with what the patients tell you. I always ask them before I tell them what it is. So try not to influence them. Uh, and sometimes they'll have low levels and they'll tell you their memory's okay. So if they're okay, I just leave them alone at that point. So pregnenolone blocks cortisol and is a GABA receptor antagonist. It stimulates excitation and inhibition of the nervous system, increases stress resistance, and acts as an anti-inflammatory agent by decreasing sensitivity to pain along peripheral nerve pathways. Remember the brain pathway from cholesterol to pregnenolone to progesterone to dihydroprogesterone that stimulates allopregnenolone, and then it makes GABA the brain neurotransmitter. That's one we don't talk about a whole lot. And so pregnenolone is one of the precursors there. This is especially the guys that are using finasteride, and then they start getting some mental issues. High dose pregnenolone can help overcome that. So you can use like 400 milligrams. You can use that for about 4 weeks. Usually 50 to 100 milligrams is a good replacement. Um, Pregnenolone sulfate regulates neurotransmission in the hippocampus and the site of memory and learning. It improves physical and mental energy, myelination, synaptic transmission, and stimulates NMDA receptors. It repairs nerve damage, blocks the production of acid-forming compounds, and enhances alertness, learning, and sleep. Pregnenolone deficiency results in a 100-fold drop in inhibiting presynaptic GABA mechanisms versus GABA A receptors. Neurotransmission is reduced, manifesting as anxiety, panic attacks, agitation, aggression, insomnia, and social phobias. So pregnenolone is sort of will help overcome those symptoms. Peripheral manifestations includes arthritis, insomnia, poor focus, memory loss, fatigue, depression, and inability to handle stress. Pregnenolone excess results in anger, anxiety, drowsiness, muscle aches, fluid retention, headaches, palpitations, irritability, and insomnia. You usually don't see too much. Usually don't see pregnenolone excess unless we're treating somebody with it and they either absorb it a lot or they just take too much. You don't see that very often. So 90 to 110 is our sweet spot in the labs. Usually anything under 50, and they pretty much have frank memory issues. So we see sometimes we'll see it at 200 to 250, and it's usually probably of no consequence, but there are some symptoms there. Okay, and lastly, prolactin is produced in the anterior pituitary, and is the hormone responsible for milk production. There's 300 other functions. Stimulates breast development, inhibits a growth-releasing hormone synthesis, inhibits ovulation in females and spermatogenesis in males, and increases dopamine secretion. Prolactin deficiency. So again, our lab values, we want it to be over 6.0, normal is 11 to 14, manifests as edginess, agitation, aggressiveness, anxiety, fidgetiness, panic attacks, restlessness, treatment-resistant anxiety, and depression. So these are usually folks that are taking two, three, four different types of medications, anxiety medications. Effects in men are impotence, loss of libido, and hypospermatogenesis. Elevated prolactin levels negatively affect testosterone, progesterone, and sex hormone binding globulin. Hyperprolactinemia in women have amenorrhea, cessation of ovarian function, loss of a libido, hirsutism, long-term risk of osteoporosis, breast cancer, ovarian cancer, chronic renal failure, hypopituitarism, autism, schizophrenia, restless leg, insomnia, polycystic ovaries, herpes, epilepsy, surgery, and stressful conditions result in hormonal failure. So that's prolactin. Okay. Here's the chart for that. Okay. So we have this quiz. This actually came from Terry Hertog, so I'm not gonna take responsibility for it or credit. Okay. So we have this quiz. I mean, you can pull this out and you can use this as your questionnaire. Okay. So what's so funny? I attribute it. I have it footnoted here.
No, I just when you said, given the wild man reputation of Terry Hertog, when you said this is a table or questionnaire by by Hertog, I claim no responsibility or association with this. I just found that very funny.
Well, I was thinking of putting my, I have my own. I could probably put that in there, but this is his anyway. And wrinkles, lost muscle tone, belly fat, poor libido, mental sharpness, sexual performance is weaker, poor muscle tone, tires easily. So 0 to 4, add them all up, and and then there's the scoring here. So we have that for everything. Okay, so you can print this out and just use this as a sort of a checkoff sheet if you want. These are the labs that we do. I think you've seen this before in other places. It's kind of a workup. interpreting the labs. So, the normal laboratory, the normal ranges are 95.4%, two standard deviations, which sometimes can be quite wide. So testosterone, this is lab cores 264 to 916. Vitamin D 30 to 100. So 31 is normal, 98 is normal, 29 is abnormal, 31 is normal. So that's, so we have to fix that, right? So what we do is we find the midpoint. We've done this before, right? We find the midpoint. So for vitamin D, we're going to add the 30 and 100 together, divide by 2, 65. Then what we do is we use one standard deviation, which is 68.1%, break that in half, calculate 34.05%. I usually just do 34%, above and below the midpoint. And then I have a calculation here for you, and that'll give you a goal of 43 to 87. I kind of rounded it off to 50 to 80. And that's how we do that. So there's a chart here, sort of optimal ranges, normal ranges. And then you can just copy this, and I have this on my computer, and then I type in, the patient's result here. And, or, if I was smart, I'd get one of my assistants to do it, but I'm not that smart, so I do it myself. I had Dr. Nerio in on Tuesday. He did it for me, and then I just did it with the patients, and it was like, when I do it myself, I've already seen it now. This time I hadn't seen it, so some of them were a little bit of a surprise to me also. So doing it yourself, there is a bit of an advantage to it, although it can take some time. I'll come in, I'll have five of these to do, and they can take 45 minutes. So, but I find it well worthwhile, and you're much more thorough, and you don't miss things quite so easily.
Right.
So here's that chart here with the normals. And then we have our calculations. I think we've done these before. Yes, no? The free T3 to reverse T3. So that's a reflection of thyroid to cortisol. We want that to be over 2.0. Elevated reverse T3 90% of the time is elevated cortisol levels. It can be high with diabetes, B12 low and low iron, but mostly cortisol. Okay, so I have this on my my lab sheet, and this is one of the things we calculate on everybody, as long as we got the reverse T3. This is one that's not all that well known. It's called Jostell's TSH index. This is when you have a low TSH and a low T3. So here's an example here. So the TSH is low. So if you only look at the TSH, you think the patient's, running, is hyperthyroid here, or close to it anyway. But if you look at the free T3, you see that that's low. And so if here's the formula here. You take the free T4, 0.9, multiply it by this multiplier here, and add the TSH to it. And then what you see is that if that's less than 1.3, then you got a brain issue. So we see this a lot in head injury people. If it's greater than 4.1, it's a thyroid issue. But if it's greater than 4.1, you won't get. That's not what we're looking at anyway. Okay, so.
Yes, sir.
There's that. Insulin resistance, fasting blood sugar times fasting insulin divided by 405. That corrects for the units. Optimal is less than 1.9. Normal is less than 2.9. There's two examples here with a fasting blood sugar of 97, which is normal, and an insulin of 17, which is normal. And you can see the insulin resistance is actually quite high. So, normal equals not normal. Okay, here we got a fasting blood sugar of 101, which is high, and insulin of 4.8, which is low, and that gives us an insulin resistance of 1.19. And so you can see that even though the fasting blood sugar is higher, is abnormal in the second one, you can actually see that it's with our insulin resistance, this patient's doing better than the first one. And
This is so helpful, Dr. Clearfield, that you have the lab calculations separate from the lecture, because you have these hidden pearls on these calculations that I talk to providers all over the place that they don't use these calculations, and that this is golden information, really, in solving more difficult cases. So
Mm-hmm.
all of that is embedded and hidden in all of your not hidden, but embedded in your lectures. On the curriculum that you teach, but having them separated, and then discussing each one really is so helpful. I forgot to
Mm-hmm.
tell you that last time, but that would be that was my only recommendation, was hoping that, maybe in your future presentations, maybe you would separate out the calculations, all the calculations that you do, into a
Right.
separate lecture. And
Actually, I do have one. I actually added it on after the thing had been, certified and then decertified. I do. We didn't do that one.
no, no, sir, we did
Okay.
not.
Remind me. I'll send you the video and now you'll have this. I'll send you this if you want it. Okay.
Please, yes, yes. And can you send me that other video as well, sir? That would be
Yeah.
amazing.
Sure. Hmm.
Please, thank you.
Yep. Okay. Um, Insulin resistance is independent of hemoglobin A1C. So that's a little tip there. Okay.
Yes, sir.
Future glucose risk. Every point over 84, there's a 4% chance of developing a blood sugar abnormality within the next 5 to 10 years. So fasting blood sugar of 94, which is normal, but our risk is 94 minus 84 equals 10 times 4 is 40% risk. 65 to 99 is normal. 90, if you get a 99, normal. 99 minus 84 is 15 times 4. That's a 60% chance of developing a glucose abnormality. So, this is where we come into play. So you get, so look at the one above, the fasting blood sugar of 97. 97 minus 84 is 13 times 4. That's 42% incidence of blood sugar, increased incidence of blood sugar abnormalities within the next 5 to 10 years. Couple that with your insulin resistance of 4.07. So this is somebody that's, sort of headed for the rocks, and we can, steer the ship away if we have enough influence.
Yes, sir.
Okay. Estrogen progesterone ratio. So we measure estrone, estradiol, progesterone. We do not have to correct for the units here. Our goal is less than 250. And if you look up here, here's the that little chart here. There's the symptoms here of estrogen excess all the way over on the left. Less than 250 is pretty much normal. And as the numbers go up, the symptoms become more severe. And then you'll see the patients will come in and they'll tell you they have all these symptoms: mood swings, depression, panic attacks. Usually they've had uterine fibroids, endometriosis, gallbladder issues when those levels are high also. A couple of examples there. And again, I tell the patients, I don't really look at the normal lab values. What we want to know is the ratio of the estrogen to progesterone. If they're still having menstrual cycles, you'd have them draw the labs on days 19 through 21. Remember, that's where you get you get the peak of progesterone and that second peak of estradiol. So that's the ideal time. If you get it right at ovulation, you're going to get a zero, pretty much a zero for progesterone. You have to be able to interpret that. Okay. So you kind of have to know when they're getting it. If they don't know when their cycle is, then you kind of have to start from scratch. That's kind of what I do. Early on, we didn't get estrone, and we did a progesterone estradiol calculation. And if you put in estrogen progesterone ratio in one of the search engines, this is usually what comes up. So our progesterone, you have to multiply it by 1,000 to get the correct units, divided by the estradiol. And normal is between 100 and 500. If it's over 500, that's a progesterone excess. If it's under 100, it's an estrogen excess or estrogen dominant. Okay, so that's kind of what we do here. So if you look at the look at the top one. So the progesterone 7.6. So it's 7.6 times 1,000 or 7,600 divided by 62. And you get 122, and your you're doing, you know, you're in the right range. Free androgen index. There is a, bio available testosterone. You need albumin and sex hormone binding globulin for that. And you can, we pretty much all have access to internet, so you can do that. That's more accurate than this, but I like this one. Yeah, I can figure it out, with my little calculator on my phone. So it's total testosterone divided by the sex hormone binding globulin times 0.288. That'll give us the right units. For men, normal's 30 to 130, optimal is 53 to 107. For women, 0.4 to 8.4 is normal, and our optimal is about 3 to 5.9. Okay?
Yes, sir.
Okay. C-reactive protein, that's our inflammatory marker. It's indicative of vascular disease. And normal is 0 to 3. Our goal is less than 1.0. And I even put the remedies here for you. So we like omega-3 fatty acids, however, what form you like it. 1,000 milligrams, usually twice a day. That's where we start. For men, you can go up to 2,000 milligrams twice a day. And then if they have joint pain, I like turmeric or curcumin, 500 milligrams, one or two in the AM, one or two in the PM. Okay. If they don't like fish oil, you can use krill oil. It's a smaller pill if you're using a pill. There's a couple companies make it in a liquid that tastes pretty good. Designs for Health is one. And then if they're vegetarian, I usually use flaxseed oil. If they have stomach burping or fishy taste, I usually tell them to put the fish oil in the freezer, and that usually takes that away.
Yeah, I started doing that with patients. You gave me that recommendation, and it works like a charm. I cannot tell you how many patients have called me back and said, that really works.
Yeah, I know. Amazing, huh?
That's awesome.
Yeah. Homocysteine usually indicates B vitamin or B complex deficiencies. Increased incidence of arterial damage, particularly coronary and carotid artery damage, heart attack, strokes, and peripheral vascular disease. Normal is less than 11. Our goal is less than 10. And then our remedy is methylated B vitamins. So not regular B vitamins. I always say, if you go to Costco and get the big bottle of B vitamins, you need about 10 of them 3 times a day. I like Apex Energetics, Methyl SP. Every company makes one. They all have methylated B6, B12, folic acid. There's usually betaine in there also. And any of the reputable companies are fine. They're all a little different, but that's the one we like.
Speaking of Apex Energetics, have you ever heard of this guy, Dr. Kazarian? Yeah. Um, he runs the Kazarian Institute of Functional Medicine. He's on the faculty of IFM, and he's supposed to be, a think tank in functional medicine. I was just ever heard. I'm wondering if you ever heard of him. He's a chiropractor, which it's not a bad thing. But I was just curious. Have you heard of him at all?
No.
He's
No.
a big proponent of Apex Energetic stuff.
Yeah.
I've never used the products before, but you like
Yeah,
it.
well, I don't know. They have something. They have a turmeric that's liquid, um, that's really effective, and we had it on our website, and we were selling it all over the world. I mean, literally, we were selling $5,000 of this stuff a month without ever advertising it. And then
Holy
one day they decided they had to be patient, so they made us take it off.
Oh my
So
gosh.
and now it's on Amazon, for 4 times what we were charging for it.
Wow.
So that's the world you live in. Okay, vitamin D aids in calcium absorption, bone strength, immune function, heart, brain, blood vessel integrity, insulin regulation. It was the go-to with COVID and all. It's a pro hormone. It aids cortisol and growth hormone. as a regulation. So we dose it at bedtime because of that. And it's a sleeping aid. It's not a sleeping pill, but it does help a little bit. And then we talked about how we titrated it. 30 to 100 is normal. Our optimal is 50 to 80. Every 1,000 units will increase the blood levels, usually within 2 to 3 months, by about 8 nanograms per milliliter. So if somebody comes in with a vitamin D, say, of 35, that's normal, but not optimal. If we give them 2,000 units, that's kind of a standard dose you would get in a drugstore. 2 times 8 is 16, and 35 is 51. So that's the bottom of our optimal. 4,000, 4 times 8 is 32, and 35 is 67. Remember, our midpoint's about 65. So that's pretty good. I usually don't do 3,000 because you need either 3 ones or a 2 and a 1 that doesn't come that way. There are 25 and 50,000 unit time released ones. Again, if you get a good quality one, they work pretty well. And it's just a once a week pill instead. It's pretty close to the same. So the 50,000 would be about 7,000 a day. So 7 times 8 is 56. It does lose something in the translation, so we don't always get that formula that way. But the individual one, we use Douglas, we use Zymogen, and we use it with a K2 now, and it's pretty close to 1,000. You get an increase of 8, and that's the way we figure it. So there was in November here. There was, in fact, remember we went and saw the lady at the microbiome lady.
Oh, yes,
Right.
yes.
And she had come to my office. There was an integrative dermatology conference in Reno that I didn't even know about. Oh, I'm here
Yeah.
for the conference. She came over to my office, and so I went over there, and I kind of snuck in, and the guy was lecturing on melanoma. And apparently, patients that have adequate vitamin D levels have much less incidence of melanoma. If they have melanoma, they heal. They do better if they have good vitamin D levels. So somebody asked them, well, how much vitamin D? Well, I don't measure it. I just tell them to take 1,000, 2,000, whatever they want. Right. And I was there. I was there with Joel, and I'm looking, and Dr. Nario. We were sitting at the same. They had like round tables there, And I said, and they threw me out, right? They told me I wasn't the scientific one,
Unbelievable. Wow.
right? So DHEA, we already went over this. Normal male 95 to 345, optimal 275 to 345. Dr. Rosier back in the day, he wanted it at 500 to 700. Can I tell you? So males, I usually do 50 to 100 milligrams. Females, I usually never go more than 25. And again, if you're using testosterone after 6 months to a year, you're going to get a negative feedback, and it's kind of a waste after that. So I don't, we kind of get rid of the vitamin, rather the DHEA after that. Pregnenolone, as you know, is the grandmother hormone. It's for memory, concentration, and if noise issues. No, what was it? Which was it? This was bright lights, right? I think the DHEA was noise. Bright lights. Is that right? We just did that. Didn't we just do that? Where do we go here? Prolactin, pregnenolone, noise. Yeah, it was noise. Noise was DHEA, right?
Yes.
Yeah. Mm-hmm. And so it's the bright lights is pregnenolone. Okay. Memory concentration. 90 to 110 is our sweet spot. Normal's 33 to 248. There's your range. 30 to 100 milligrams a day. 100 milligrams is pretty good for memory. 400 milligrams if you're having a lot of sort of anxiety, agitation, but you can only use that for up to a month. Hematocrit, the percent of red blood cells in the blood volume. Um, Reno, we're at 4,500 feet, so it's a little bit higher here than the sea level. So 52, 53 is not unusual. It will increase with testosterone. The books say you need to do a phlebotomy over 55%. And again, we went all through this, when we went through testosterone. It does not cause blood clotting. It does not cause polycythemia. It increases red blood cells, but you don't get white cells, you don't get platelets, you don't get uh, the increased heart attacks and strokes. Technically, you don't really need to do the phlebotomy, but everybody feels better. Sometimes the patients say they felt heavy and they felt a lot better after the phlebotomy. They feel lighter. So whatever
Yeah.
that's worth. I always look at MCV, mean corpuscular volume. About 80 to 97 is considered normal. FL is I have to fix that. That femtoliters, that's the measure, or FL. Less than 80 is an iron deficiency. Over 97 is a pernicious anemia. So normals between 80 and 97. I tell the patients it's a cell size, and that gives us a clue. And usually when the MCV is high, the homocysteine is high also. So they're kind of a check on each other. Prolactin levels. Um, Prolactin measures treatment-resistant anxiety and depression. When it's low, less than 6 is treatment-resistant anxiety and depression. Greater than 20, when it's really high, it usually has to be 50 or higher for you start thinking about a pituitary adenoma. Breastfeeding, they'll be over 25. IGF-1, that's the active portion of growth hormone. So we use that as a screen, 200 to 250. Dr. Gordon, of course, likes to do everything. But again, it gets to be kind of expensive. And there's a couple of, so real growth hormone, we use that. We don't, that's not our first line. But 0.8 to 1.2 units 5 days a week is the usual dose there. The peptides, and if you can get them now, are CJC 1295 with ipamorelin, ibutamoren 10 to 25 milligrams. That's the oral dose. So that'll get you there. And then, there's a whole bunch of thyroid stuff. So TSH, that's your detective. Our goal is 0.8 to 2.0. Free T3, this is the usable portion of test thyroid. This tells you whether the thyroid molecule is getting to the tissues. We want it in the upper third of normal, 3.4 to 4.2. Free T4, that's the storage component. That's your synthroid, 0.85 to 1.73. To me, that doesn't tell me. They do TSH with a reflex to free T4. That doesn't really tell me a whole lot, I don't think. I don't know how you feel about it.
No, it does not. Me
Yeah.
neither.
Reverse T3, it's usually due to cortisol issues over 15. We start seeing cortisol symptoms. We did the free T3 to reverse T3 ratio. We already talked about that. The TSHI, we talked about that. Thyroid antibodies, so you do TPO and thyroid antiglobulin. And TSI is for Graves' disease, hyperthyroidism. Lab A is LabCorp. Lab B is Quest. There's a couple of labs that'll tell me less than 60 is normal for both TPO and antithyroid globulin. They're kind of out in the country there. I don't really know where they get them from. TSI, you want that less than 130% from baseline. That's the Graves' disease. I almost never see that. Ferritin levels. So ferritin, B12, and folic acid, when you have thyroid antibody issues, are going to be off. So we always check those. Ferritin levels, that's your iron store. 90 to 110 is our goal. Less than 50 is an iron store deficiency. We like iron glycinate as a replacement. We use optiferrin. We don't get the GI issues that you get with sulfate and gluconate. B12 and folic acid, however you want to replace those. We want the B12 over 500 or 700 and the folic acid over 500. Okay, there's the dosage schedules here. I'm going to have to get going here. I'll send you this if you want.
Absolutely. Yes.
Okay, a couple of things I've noticed that we retweak. If you want next time, we can just sort of finish this up. There's the dosage schedules, how to treat them. I know we've done it, from time to, overall. And then we have some supplements here that we go over just pretty simply. Here's a chart here at the end. I think you've seen this before, with the each hormone. It's got the doses here, functions, and deficiencies. So right there's everything you need to know about hormones right there in
Yes,
those 2 pages.
Dr. Cooper, can you send that to me? That would be amazing,
Yeah,
please.
yeah. I'm going to send you this whole thing. Okay. So
And
that's my
then,
little booklet. That's for practitioners. I'm gonna dumb it down a little bit for patients, I think. So we'll have that. And you
oh,
can see here we got 126 references here. So remember,
that is
they
awesome.
told me I'm not scientific. So it's.
Well, they prove the fools that they are when they say stupid stuff like that.
Yeah, I know. So anyway, so that's my little booklet. That's going to be, if he likes it. I sent him this that was uncorrected, and it didn't have all the references. So that'll be his chapter in a book on hormones. I don't know. Tell me what you think.
Oh, it's amazing. Absolutely. Please. That's awesome, sir. Yes. The what was I going to ask you? Oh, and you were would it be okay if you sent me that lecture on the calculations that that
Yeah.
separate?
Yeah,
Okay.
I'll send you that, and I'll send you this. The calculations are on in here, in this, right there. So, I'll send you that. You know what? Send me a within the next hour. Send me because I'm gonna have to get going here. So,
Oh yeah.
send me a text. So I'll send it to you during the day. Okay.
All right. Sounds good. Thank you so much, Dr. Clearfield.
Okay. Talk to you next week.
Yes, sir. And maybe hopefully next week, if it's okay with you, I'll have Tina here, and then you can look over my shoulder as I inject that.
That'll be fun.
um, um, oh, you know those what do they call them? What do you call those tablets? The yellow jacket, the green jacket, the something jacket. Um, those tablets that I had purchased.
Oh, for weight loss.
No. Just it's for energy.
Oh,
It's
it's something called Green Jacket. We get it from Nootropin.
yeah. I ordered a bottle from you when we got the when we ordered the Juvederm from your office, but that supplement hasn't arrived yet.
I think there might be a problem with that. I think they don't make it anymore, but I think I remember Christy's telling me something. So
Okay.
let me check when I get to the office, and I'll send you your money back when.
No, you absolutely not send my money back. No, sir.
Okay.
Never.
But let me check on that. Remind me when you send me that text. Remind me about the green jacket too. Okay.
Okay. All right. Sounds good, sir.
Okay. I'll talk to you again.
All right. Look forward to seeing you next week, sir.
Okay. Okay. Thanks. I like this. This was good.
Sir.
All right.
Take
Oh,
care.
there you are. Okay. All right. I'll talk to you soon.
All right. Take care, sir. Thank you.
Bye bye.